Hi guys, sorry I couldn't be with you today, but I decided that I wanted to send you a video to start some board prep. And like I mentioned, just going with the outline of the book and of most books, and of the fact that considering the fact that the musculoskeletal system is a very important system where most of your questions are coming from, one that you should know very thoroughly. I am going to start covering some content related to the musculoskeletal system. So I will start with that today, not going through all of it, but going through some parts of it. Okay, so the planes and axes, or axes, however you want to say that. I think that it is good to review this if you have forgotten a little bit about this, because it can come up in ways related to, as it says in the bottom there, motions, exercises, or stability. It's not, again, the board is not a let me test your knowledge type of exam. The board is really, can you be an efficient therapist and a safe therapist? So not to say that there's not knowledge-based questions like what is this and what is that, but really the board is trying to see, are you competent enough to treat a patient correctly? And are you competent enough to make sure you don't hurt a patient and treat them safely? That's the main goal of the boards. That's why when we talked about the boards in the past, and when we've given you board style questions and so forth and so on, it usually is not, which plane what does the sagittal plane do? It divides the body in halves. Like, that is not important per se for you to treat a patient, okay? What's important is knowing that, so you understand what it looks like, so you understand what motions occur in it, so you understand, what plane you're working in, or when asked if you're working on sagittal activities or whatever, you know what they're talking about. So it's a basis that you build upon when it comes to movement and exercises. And that's how you got to think about when you're reading through the book and you're reviewing things that are maybe, again, kind of like these basics. It's not that you have to memorize these to the point that you're going to get asked, what is the frontal plane? What is the transverse plane? You really got to try to formulate questions in your head related to, how can this be applied in treatment? How can this be applied in an eval? Can I read this eval, read what the therapist notes are saying if they say to work on sagittal plane movements, and understand that as a therapist, because that's real life, right? So you really want to make sure that you focus on what motions occur in the planes and or axes, which you should know how they relate, or what exercises can be done. If they put it in the form of motion or they put it in the form of exercise, you should still know. And so some examples are there in the chart. That's just a chart that I found online that kind of shows what I'm trying to say. But again, you can look in your book for the actual planes and movements, or look back in your notes or anything that we've given you. But really focus on planes and axes, more on motions, exercises, and or stability, rather than knowing, oh, this plane divides that or this plane divides this. So I provided you these questions to kind of show you what I mean, right? So the first question says, the plan of care requires increases in lower extremity strength for a patient in the sagittal plane. Which of the following interventions would be the most effective in reaching this goal? So there's two things that I would look for in this question. Number one, when I'm reading through the choices, which of those motions or exercises are happening in the sagittal plane? And that means that you have to understand that the sagittal plane goes back and forth, and you're looking at motions that go back and forth. And then the second thing I would look at is, what is a strengthening activity? Because if you choose an exercise or movement that is in the sagittal plane, but it's not for strength, then you're not looking at the whole question. You're only looking at part of the question. And this is where, when it comes to board questions, you really got to pick out those keywords. To me, the keywords is the plane and the fact that they're looking for strengthening activities, which means I have to focus on strengthening activities. So I'll give you a few seconds to read the options, which are A, repetitions of resisted TheraBand hip abduction, B, seated repetitions of hip flexion and knee extension with an ankle weight, C, repetitions of passive range of motion of the knee flexors and ankle dorsiflexors and plantar flexors to the end range, and D, seated repetitions of hip internal and external rotation with no resistance. Give you a few minutes, or not minutes, seconds, because we don't have that much time, but I'll give you a few seconds to think about it, to weigh out your options. Okay, and so the best answer for this question is going to be B, okay? Because it has those two components that we talked about. So hip flexion and knee extension work or occur in the sagittal plane because they are back and forth motions. And there is an ankle weight, which means resistance, which means strengthening. In D, the plane that they're talking about is transverse, so that makes it incorrect. In A, the plane that they're talking about is frontal, so that makes it incorrect. And in C, although those motions do occur in the sagittal plane, passive range of motion does not result in strengthening or increases in strength. If you are moving the patient without them doing any muscle work, then you're not increasing strength. You're increasing range, you're increasing mobility, flexibility, but not strength. And the plan requires strength interventions in the plane. So although B and C both are motions or activities that occur in the plane, you have to look at the strength component and understand that a resisted ankle weight activity will result in strengthening versus a passive range of motion activity. Next question says, the patient is experiencing instability in the frontal plane, resulting in loss of balance. Which of the following interventions should the PTA incorporate in this treatment plan? So again, you got to think about how that plane runs, what motions occur, and the options are A, anterior posterior weight shifts, B, lateral weight shifts, C, forward stepping, and D, backward stepping. Now, if you can really picture these activities in your head, you will probably notice that all of them go back and forth except B, which is lateral. So test taking skills, if one stands out, it's either absolutely right or completely wrong. In this case, it's absolutely right. It's the only one that occurs in the frontal plane, while all other activities occur in the sagittal plane. So it stands out because it's the only one in that plane, and it's meant to stand out. So musculoskeletal anatomy. In your books, in Get Body Smart, in your kinesio book, in whatever handouts we've given you, you have obviously list of muscles, origins, insertions, nerves, actions of the whole body, at some point, and we have covered it all throughout term 3 and 4 particularly. And in your book, you have those charts. So anatomy is not going anywhere. You're going to have anatomy in your boards the same way you're going to have anatomy in your evals. You got to know your anatomy, like we have always said from the very beginning. Again, we are in the musculoskeletal system, which is, again, one of the big ones. So you definitely have to know muscles and bones. What I put as the key things when you are studying is focus on major primary muscles and their actions, okay? And I put major primary because although we do cover a little bit of everything, if you're stuck, if you feel like you're overwhelmed, if you feel like you're studying too much, and you don't remember what the, I don't know, obturator, occipitus does or something, which is your eye muscle, like, you're gonna be fine. Okay? They're probably not gonna ask you about that muscle of your eye. We're not optometrists. We don't deal that much with it. Not that we don't at all, but that's not the muscle they're gonna focus on. You know, hand muscles, we give you a little bit of it, some intrinsics and stuff, some ones that we kind of told you to focus on. But again, you're probably going to get asked about the big guys that we deal with: backs, hips, legs. And also when I say primary movers or primary actions, those little details about, I don't know, this muscle, it helps a little bit in the first 10 degrees of flexion, pull a tiny bit, like all of those details. Not that there can't be a question about it, but that's not where I would put my focus on, especially if I struggled with just the basics knowledge, okay? If you're so good in your anatomy that you know your prime movers and stuff, and then you want to focus on those details because you think there might be a question on there that you can tune up or spruce up, cool. If not, there is no need for you to really emphasize and freak out because you don't know that this little piece of the muscle attaches and helps a little bit right there. You really got to know the big guys who do a lot of the work, okay? And yes, actions is important, okay? Action is the most emphasized thing because it's the main thing that we're going to do in regards to exercise and movement, again, and how to use that muscle or how to strain that muscle or how to stretch that muscle. And if a muscle has several actions, you should know all the actions because that could help, as it says there, differentiate one muscle versus another where they kind of do the same thing. Because if you have 5 dorsiflexors, but then they ask you about dorsiflexion and inversion, that's going to lead you to a specific dorsiflexor versus other dorsiflexors, right? So you do want to make sure you know all the actions, okay? Now, the origins and insertions, which is the 3rd bullet point, I know that we made you learn those and we stressed those. And believe it or not, there's not going to be, like our knowledge-based exam, so many questions that says, what is the origin of this? What is the insertion of this? You should have a general idea, okay? Because, again, if you have to rule out or choose something where it does say the patient is having tenderness at this little point, or where should you put the ultrasound over this little bony prominence or this attachment point, you may get questions like that related to origin and insertion. But there is not going to be any any questions on the boards that is just like, what is the origin of this, or what is the insertion? They're not. Again, it's not practically important to you as a treating therapist. How it comes about in real life is that should you be holding it here because that's putting your hand on the muscle? Should you be palpating here because that's part of the muscle? And you got to know that's part of the muscle by knowing that it attaches there, right? So I wouldn't focus as much on origins insertions, especially if they're very specific. Like, you know how some origins are like the lateral 1/3, just know it's around the side of the clavicle. If it's 1/3, 1/4, 1/8, doesn't matter. Okay, you should have an idea though where things are. Okay, because if it is asking you, you know, where do you expect the patient to be tender, or where do you expect to put your hand or something, and you're picking something on a foot when it's on a shoulder, now that's bad. Okay, so you should have an idea of where those things are. But if you don't remember if it's the lateral 1/3 or if it's the linea alba versus the underneath the trochanter or something, as long as you know it's around there, you can probably figure it out. Okay, but the actions are going to be the most important thing that you have to know about your muscles. Okay, the other thing that is very important is the nerves. Okay, I know in the beginning we started more with muscles, origins, and insertions, and then we kind of added the nerves, especially as you got closer to neural. But really, real life, nerves and muscle actions are very important. Okay, so you should know nerves associated with the muscles or the muscle groups. And myotomes is where you're going to go into with that as well. Okay, the neural and the musculoskeletal things are going to overlap. So you might think, oh, I thought we would talk about myotomes and neural topics, but it's related to musculoskeletal, because if a nerve is damaged, it's going to affect the muscle function. Okay, so just make sure that you kind of tie those together. It's going to come out in one way or the other. Okay, so nerves and actions, I would say, are the most important. And as always, if you are not so great in this area, then make sure that you make it in a way that's easy for you to read, as we have always said. Break it down by section, by body part, by joint, or by things that you can group together, like these are all rotators, or these two muscles do the same thing, and then that way you can help remember that better rather than individually trying to memorize everything. Okay, questions related to anatomy, again, are going to come not so much in what is the origin, what is the insertion, what does this muscle do, but more in relation to manual muscle testing, to how do you strengthen this muscle, how do you stretch this muscle, how do you increase range by doing what action, if there's a nerve damage, which muscle is it going to affect, which action is it going to affect. And then as we start to get into pathologies and conditions in another musculoskeletal lesson, you will see that that will also trickle into the anatomy part, where it may be like your patient has an easy one that we always do, lateral epicondylitis. What muscles would you expect to be, weak or whatever? And so you should know the idea of the pathology and the muscles and the motions. But that's a little bit more layered, so we'll get to those when we get to those. All right, so let's look at some of the related questions, right? So a PTA tests the strength of a muscle by placing the patient prone with cervical rotation to the left, having the testing upper extremity fully internally rotated along the side of the trunk and shrugged towards the chin. That means, if you could see there like that, because it's along the trunk, it's internally rotated, so not out, but in. And this shoulder, if the head is to the left, is up like that, right? But you're laying down, of course, prone. Then they instruct the patient to try to reach towards the leg. So the shoulder, let me show it on the side, the shoulder is up, but you're asking them basically to go down, right? While you resist, or while the PTA resists in the mid shaft of the humerus. What muscle is being assessed? So options are upper traps. And so, of course, this is an MMT question where you have to try to really picture what they're describing, what motions they're mentioning, and then understand the principles of manual muscle testing to try to figure out anatomically what muscle they're talking about. So you have upper trapezius, posterior deltoid, latissimus dorsi, and triceps brachii. Okay? If you just think of how to test some of these muscles, many of which we already know how to test. Maybe you've never really tested the upper traps or the lats, but you definitely tested in lab and in your, some of the basic ones like the triceps and the posterior deltoid, right? Both triceps and posterior deltoid dealing with the extension part, but only shoulder extension. That whole, you gotta rotate and you gotta shrug and all that. We've never done that to test those two muscles, B and D. So I would eliminate B and D, okay? Because I'm gonna use what I know to try to figure out what maybe I don't know or what I'm not so sure about. So knowing how to test the posterior deltoid for shoulder extension and the triceps brachii for elbow extension tells me whatever they're describing there, I've done those. Those are not it. I can eliminate those, right? Then you're left with upper traps, or at least that's how I broke it down. That's how I started, right? Left with upper traps and lats. Upper traps has a shoulder shrug component, but the other stuff, you have to internally rotate and then you're resisting like this downward motion. That sounds like too much for the upper traps, right? Because the upper traps is a scapular muscle. It has no attachments to the humerus itself. It has attachments to the spine and the scapula. So while it can help with lifting the scapula and then maybe lifting some of the shoulder complex, all that internal rotation and all that has nothing to do with the upper traps. Which leaves me with the lats, which makes sense. Because again, the lats does internal rotation. The lats does extension and adduction. So that's literally how your arm is, right? When they're talking about the testing position. And what they're testing, not only did they put it in the positions that it does, but they're testing this motion where you kind of push up, which is like you pushing up off the bed, which is one of the big things that the lats helps with. Pull up or push up. So that resistance makes sense now. It's the only one that if you think about what it does, it kind of has all those components and it makes sense. Okay, so the answer there is C. A PTA is currently working with an athlete post-shoulder injury. Which muscle would move the 90-degree abductor shoulder anteriorly? So they're telling you that you're starting like this, 90 degrees abduction. Would move it anteriorly, aka horizontal adduction, ATD, horizontal adduction. You have sternocostal head of the pec major, clavicular head of the pec major, inferior fibers of serratus, pectoralis minor. So this is one where I told you origins and insertions are not the most important thing, but if you have an understanding of how origins and insertions work, of where they are or what they're describing there anatomically, you might have questions that you need to know a little bit about that, and this is one of them. Pec minor is a scapular tilting muscle. It's connected to the coracoid and just kind of pulls it back and forth. All this stuff about the shoulders abducted and it pulls the whole arm, basically, the pec minor is way too small to do all that. Okay, serratus also has nothing to do with the arm. And when I say the arm, I'm talking about this part of your body, right? Origin and insertion wise, they are not connected to the humerus. They're not connected to the arm. So it cannot be C or D if it's doing shoulder stuff and moving the arm. So you're left with the pec major, but then they're specifying one part or the other part, right? Is it the sternocostal part or is the clavicular head part? Again, you have to think of what part can possibly be attached to that humerus. If you have an attachment or an origin, sternocostal, meaning ribs and sternum right here, this part of the pec, okay, that is not the part that's attached to the humerus. It's all the way midline. The part that's attached to the humerus is the part that goes out over here, which is going to be probably that B, that clavicular, because the clavicle goes all the way out to the side. So that makes a lot more sense. So the answer there is B, with that insertion that is attached to the actual humerus. So yes, there are going to be anatomy questions. Yes, either related to MMT, to exercise, to motions, and sometimes those origins and insertions, you might not memorize them exactly as they're written, but you should have an idea of how that works rather than just the point of memorizing them. Okay, so MS, of course, anatomy. There can be many questions. So here's some more. I gave you a little more on this one because it is what it is, right? So a PTA is working with a patient who suffered a strain on the head extensor muscle group. Which of the following muscles would most likely be affected? Spinalis cervicis, longus capitis or capitis, longus coli, or sternocleidomastoid? I'll give you a second to think about it. Okay, the correct answer is A, okay? And while maybe the spinal muscles are not gonna be as asked about as like a shoulder, a knee, or a hip or something, you still gotta know those, right? We still taught you those. If you remember, longus capitis and longus coli are anterior muscles. They're here, okay? And sternocleidomastoid is pretty much here too, okay? Whereas spinalis, which is part of the erector spinae, I love spaghetti, iliocostalis, longissimus, and spinalis, which is right there, spinalis cervicis, are all in the back, okay? So the only one that's in the back that can extend is that spinalis. And spinalis cervicis, aka spinalis neck, neck extension in the back, makes sense. The rest are all in the front. That means they are flexors, okay? Now this last question is a very loaded question, right? Because it's a pediatric neurological patient. It's mentioning a condition, myelomeningocele. It's mentioning basically a myotome. And then after knowing the myotome, you have to know what muscles are working and what muscles are not. And then once you know what muscles are working and what muscles are not, then you have to look at the action that those muscles do and answer the question. So this is a very complex, loaded question, but I threw it in there because I want to throw you the hard ones, not the easy ones. The easy ones you should get and you're going to get, right? It's figuring out some of these hard ones. And I want you to see how to layer those questions and how to figure out these questions, right? So remember that myelomeningocele, which is a type of spina bifida, is like a spinal cord injury, right? So you have the spinal levels starting from C1 to L5 or S1, and wherever the lesion is, wherever the spinal cord injury is, or wherever the myelomeningocele lesion is, below it, things are going to be messed up, right? So if you are having a lesion At L4, L5, very low in the spine, you already know that this patient probably can move their arms fine, move their trunk fine. Something in the legs is affected, right? And if you think of myotomes and you think of DTRs, L4, L5 is going to affect like around the knee area, because you remember like even when you did DTRs or when you did dermatomes, L3, L4 was always like upper thigh, knee, and then L5, S1 was going into like ankles and foot. So if everything below L4, L5 is going to be messed up, aka let's say knees, shin, calf, ankles, and feet and toes, then the one that is going to have normal function, which is what the question is asking, which of the following movements would most likely have normal function if this patient has an L4, L5 lesion of myelomeningocele? The one that would have normal function is something that is above the knee, like a hip, trunk, arms, whatever, right? So let's look at the options and see if you have stuff below the knee and stuff above the knee, right? A says lifting the forefoot and toes off the ground. Toes and foot, that's very low. Probably not. Extending and controlling the knee from standing to sitting. Probably not. Okay? Pointing the toes. Toes, probably not. Flexing the hip to clear the foot off the ground. Yes. Your patient's hip muscles should be working pretty good because of how low that lesion is. So D is going to be the right answer. All right, so open pack and closed pack, or loose pack and closed pack. I know I'm blocking the tables, but you have your own tables in your books. And honestly, this table, because it's so squished and is not that clear, so you should be going back to your books. However, I just wanted to remind you to not forget about these concepts. These are important because anytime they're asking about how best it is to mobilize a joint, move a joint, how unstable it is versus stable, how supported it is versus not supported, and so forth and so on, a lot of the times you're going to be referring to or alluding to open pack and closed pack. And if you remember, your joint are two bones, and they rub together, come together, whatever, in some type of way, depending on what they look like, condyloid, whatever. A lot of times we look at it like this, one concave, one convex, but not all joints are like that. But either way, open pack is just the motion or position where there's a lot of space in between. That means movement can happen. Closed pack is where the position where there's not a lot of space in between, which means it kind of locks in, or there's not a lot of movement that can happen. So you're going to have a more stable position when it's in closed pack. You're going to have a more movable, unstable, or ability to stretch or mobilize better with an open pack or a loose pack position. And what else did I want to say about that? Oh, and it doesn't necessarily have to be the end range in one way or another, right? Like if you look at the shoulder, the open pack position is 55 degrees of abduction and 30 degrees of horizontal adduction. So it's like, well, I can't really show you, but you know, somewhere, let's say down here, and then somewhere weird down here, like in the bottom, but not all the way down type of thing. So that's a weird one, but it is one that you should know. So it's not necessarily like at the end range or at the beginning range. Sometimes it can be somewhere in the middle, and you just have to know it, right? Also notice in this chart, and if you look at your charts in the book, that the joints are named anatomically. And so again, it goes back to anatomy and anatomy basics. If they say glenohumeral, if they say tibiofemoral, you should know that they're talking about knees and shoulders, because they're not always going to say knees and shoulders, right? And that's just basics, but just again, if you got to brush up on that, make sure you look at that. So here are the related questions. First question, which is the most vulnerable position for dislocation of the hip? And so vulnerable, dislocation, those keywords are going to tell me I'm looking for a loose pack or open pack position of the hip, which again, you got to maybe refresh, look back at, look at these options and see which one you think. And sometimes it helps if you really don't remember to kind of feel it, or try it if you have the ability. If you really are just trying to guess, like do it and see if it feels like very congruent or not that tight. Sometimes that works, sometimes that doesn't, because again, they're very specific and very random sometimes, but that can help. But the answer for the first one is C, which is the loose pack or open pack position of the hip. 30 degrees of hip flexion, 30 degrees of hip abduction, minimal external rotation. When it comes to the second question, okay, which position would provide the most stability? Now you're looking at the closed pack position, or you're looking for the closed pack position. And we just saw it, or I just discussed it in the previous one, that it is going to be B. That abduction, oh, I was looking at the open pack, not the closed pack, I'm sorry. So we didn't discuss it, but it was on the other slide. And the closed pack is external rotation and abduction, where you're really going to get that congruency. So that's going to be the answer for that second one, B, external rotation and abduction. All right, so continuing with anatomy, this is just saying don't forget not only those anatomical names, not only those muscles, but have an idea of other structures around the joint that may get asked about, like ligaments, like tendons, which of course are just named after the muscle, but you know, still understand that a tendon is attached to a muscle. Capsules. With capsules, a big one is capsular patterns. Capsular patterns, there's always some questions on that I've seen. And so a capsular pattern means if there is an issue with the joint capsule, which again is the bundle of ligaments that goes around the joint, in all synovial joints, if there is an issue specifically with that part of the joint, your joint will be restricted in this order of movements, okay? So if you look at the little chart that I put there, for example, a big one that, again, almost always comes out, almost always gets asked about is the shoulder capsular pattern, which is external rotation is the most limited, followed by abduction, followed by internal rotation. So in a question, anytime you see that they're talking about those movements being the worst or the most limited, your answer or your option should point to a capsular issue or working on the capsule or treating the capsule, rather than saying it's a muscle tear or whatever, right? When it comes to ligaments, those around the knee, we know very important. If you don't know all of your ligaments, at least go to the knee ligaments. They're always going to ask about ACLs, PCLs. The knee is just one of those very important joints that every structure matters, including all its ligaments. If you don't know the ligaments of the shoulder, you might be okay? But the knee ligaments for sure. I would say maybe ankle ligaments are another big one, just because pathologically there are conditions related to these specific structures. So ankle ligaments important, knee ligaments important. I would say even hip ligaments are important. Shoulder is so much more movable, and of course there are still ligaments that you got to think about, but there's not as much ligamentous injuries rather than labral injuries or dislocations completely or subluxations. Maybe AC acromioclavicular ligament might be an important one just because of AC joint separation. But I would say definitely you got to know those knee and ankle ones. You know, what is part of the deltoid ligament in the ankle, stuff like that. Other structures I mentioned in there, meniscus, which again, knee is just like very important to know everything about it. Intervertebral disc, because that's related to slippage, to herniated nucleus pulposus, which is basically a herniated disc. So those things, don't forget about that anatomical aspect either, okay? I would say again, knee ligaments being the big one. So here are some questions related to that. The first one is about a PCL, right? So it says, an athlete just received a PCL reconstruction surgery. Which of the following is incorrect about the PCL? Options are A, it prevents posterior translation of the tibia on the femur. B, it prevents bands of the PCL, posterior bands of the PCL are tightest during knee extension. C, PCL is attached to lateral meniscus and not medial meniscus. Or D, PCL helps with medial rotation of the tibia during full knee extension with open chain activities. So of course, pay attention to the fact that it says which is not true or which is incorrect, because anything that is correct, you should be ruling out, right? So the first one is correct, because that's exactly what the PCL does. So that should be ruled out, not because it's right, but because it's wrong, since the question is asking about what is not correct, okay, what is incorrect, okay. Second one, posterior bands are tightest during knee extension, okay. It's a hard one to kind of just know that, but you can imagine if it's preventing the back of the tibia from moving too forward. I mean, if it's preventing the tibia from sliding too far back, then it's going to create tension in the back to stop it from moving. So again, it's not like you're going to know everything, but sometimes think through it critically and see if that makes sense. That makes sense to me. I'm going to leave that one alone. C, PCL is attached to the lateral meniscus and not the medial meniscus. The ACL, no, that's true. PCL is attached to the lateral meniscus, right, and not the medial meniscus. So yes, that's correct, okay. What I was going to say is the ACL is the one that's attached to the medial meniscus, because if you think about the terrible triad, it's ACL, medial meniscus, and medial collateral ligament, right? So that tells me that the ACL is attached to the medial, therefore the PCL is attached to the other one, which is the lateral. So C is correct, right? And then D, PCL helps with medial rotation of the tibia during full knee extension with open chain activities. What they're talking about there is the screw home mechanism. So although knee rotation, medial and lateral, is not a full movement, like hip internal or medial rotation, there still is a little bit of rotation in the knee in the screw home mechanism. And so if you have the knee, I'm trying to show you an example here, medial rotation would be opening it up, and lateral rotation towards the outside would be locking it in extension. So actually the PCL helps with that lateral rotation. So that one is incorrect because it says it helps with the medial rotation, And that is not true. It helps with the lateral rotation or the locking, which is a screw hole mechanism. Okay, now that's a very involved question if you don't remember that stuff. But again, questions can come at you in many forms. I hope that you have enough information somewhere to at least rule some things out to give yourself a better chance. Okay, and then next question says, using the picture, so I gave you a picture. Do remember that your board will have pictures, will have videos, and then we'll have, of course, written questions like this. So using the picture, which is if you're looking at it on your left-hand side, which ligament's integrity is being tested if the therapist is applying pressure indicated by the arrow. Okay, so they're putting pressure. If you look at the leg and the leg that they're touching, where the line is and where the arrow is, they're putting pressure on the inside of the knee going out, right? On the medial aspect of the knee, pushing towards the outside. So that is going to be testing the integrity of the lateral collateral ligament, okay? Because when you're putting pressure and creating pressure on the outside, which is the lateral side, you're pushing on the inside, but you're creating pressure on the outside, you're gonna test the ligament on the outside, which is the lateral collateral. Even though it seems like they're pressing, even though you may think, oh, but they're pressing the medial, but the force is directed on the lateral. Okay. So the last topic I'm going to cover today is posture. You want to make sure you look back on your postural concepts, starting with what is good posture, right? Or ideal posture. And that is going to be analyzed by either a picture, like what you see there, with a patient standing in front of a plumb line, or some type of model standing in front of a plumb line, and you understanding kind of where that's supposed to fall on the plumb line for it to be the best that it can be, like through the external auditory meatus at the head, anterior to the knee joint, maybe passing through the greater trochanter, stuff like that, so that when it is not in those places, you can know that it is not normal. Also, make sure that you understand the terminology for postural deviations, the ones that, again, we have discussed, like kyphosis, lordosis, scoliosis. You may hear about rib humps when it comes to scoliosis, so just be familiar, like where does the rib hump fall, if it's left-sided or right-sided scoliosis. So if you have the this is concave. If you have the concave, it's hard to see because you can't see my whole body, but if you have the concave side to the, in my point of view, thinking of my own body anatomically, the right, then the convex side is going to be on the left, so your rib hump is going to be on the left, right? You should also understand the anterior tilt and posterior pelvic tilt, because neutral is ideal, right? So when it's going into kind of a exaggerated anterior or posterior, what type of issue does that cause? Is it a flat back? Is it a sway back? Is it a crouch position? Is it causing, other things to happen on top of that? What things are tight? What things are weak? Like all of that stuff that we talked about related to posture, okay? So we'll go into some questions so you can see what I mean, and then we will finish up with this lesson today. So here we go. A patient is standing at the plumb line, PTA, notices in the lateral view a posterior pelvic tilt, the greater trochanter falling anterior to the line, hip extension occurring, as well as thoracic kyphosis. Thinking of that, what posture is being described? So again, you really, the issue sometimes with the boards is that they write stuff out and you have to picture it. The way that they are trying to fix that is by adding more pictures and more videos, but sometimes they do write it out. And you have to be able to really visualize it. So basically what we're looking at here is the rounded upper back because of the thoracic kyphosis, and then your butt kind of tucked in with your hips pushing forward because they're extended, not flexed, right? So what position is being described, or what posture is being described? Flat back, scoliotic, sway back, or crouch posture, right? And then again, always start with what can I eliminate? What can I get rid of? I would get rid of scoliotic, right? Because first of all, you typically don't really see scoliosis from the lateral view, which is what they're looking at the patient in. You have to look from the back, right? So you can see, maybe leaning this way or leaning that way to really get a good look at it. And it might cause some of these things, but might not. Like there's no, it's really more an upper body thing, not so much things with the posterior tilt and all that. I mean, you can't say it can't happen with scoliosis if there's other stuff involved, but it's not typical of, right? So because of the view and because it's not typical, I would eliminate scoliosis, right? Flat back and sway back are similar in the sense that they do both have posterior pelvic tilt. So I'm gonna leave those there alone for now. The other option that is there is crouch posture. Okay. Crouch posture is like exactly what it says. Like if you're crouched over, you're leaned over, like if you're looking down at something on the ground, right? And that's typical, again, maybe of like a Parkinson's or a hip flexor tightness or something like that, but it's causing more hip flexion rather than extension. And it does specifically say extension. Okay, so I would eliminate that one because of that. Okay, so again, we're going back to sway back and we're going back to flat back. Okay, flat back and sway back, as I told you, are very similar in regards to what they look like. However, the thoracic the thoracic kyphosis is what leads me to say sway back, because flat back, you have the posterior pelvic tilt and the hip extension, but your upper back is not involved. Whereas sway back, it creates kind of that sway because of the top part sticking out and then the back kind of being sucked in the other way. So like an S almost. But not in the scoliosis way, in the lateral view way. Okay, so the answer there is sway back. Now, in this one, I didn't give you another multiple choice because I do want you to think every time you're studying a topic. Really, I would encourage you to make up your own potential board style questions every time you read something and be like, how can this be asked? Again, particularly clinically, particularly things that we deal with, if we're going to test it, if we're going to treat it. So the critical thinking question that I put in there is, what if this question was asked related to interventions? What was tight? What was weak? Would you be able to pick those things? Would you be able to pick the tight muscle or the weak muscle, or what exercise can you do to fix it, right? So we're thinking somebody who has thoracic kyphosis, and then a posterior pelvic tilt but hip extension. You're probably gonna have tight, what do you call it? Hip extensors and back extensors because of the position that they're in, right? You're probably gonna have overstretched back, upper back muscles, like your scapular retractors and all that, because of that humpback type position. So how would you fix that? Is you got to go in there and be like, whatever is tight, stretch it, whatever is weak, strengthen it, and then that's how you would pick your interventions based on that, right? So sometimes, rather than having a multiple choice question, go ahead and be like, what else can be asked about this? Put it informed, like if you were in a clinic, how can you make it a treatment or a problem solving? Because that, again, as I emphasized in the beginning, that is what the board is about. They're not there to just test your knowledge and be like, what is scoliosis? What is this? They're there to give you a test and give you a license to see if you're competent with effectiveness, ethics, treatments, safety. And so most questions are going to come based on that. If you can read the eval and understand what's messed up, how to fix it, if you can come up with an activity based on the condition or based on the issue. And that's really what they're trying to test you. So that's how you got to think about all the topics as you go through them. All right. So I hope this was interesting and this helped you for now, since I really haven't been able to do these kind of live. I like to at least record a little something and give you some type of resource that you can look at. I want to end off, of course, by saying thank you. And I want to end off by saying that for those who were not able to hear me in class when I've said some tips about the board, some tips I've given you already about what to focus on, at least in these subjects, and also, how to think about it clinically and safety-wise. The other tips I would give you is do exactly what we're doing with these questions, which is every time you get to it, try to see what you can pick out that can help you either land on something or eliminate something, okay? Try to see if you can figure out the answer in your head, as we've always told you, and then see if it's there. There's a big chance that's probably it. Doesn't mean you stop reading the other options, because you want to make sure that you didn't miss something, right? But chances are that whatever it is that you came up with without even looking at the answers, that's probably right. That's why it popped out in your head. If not, eliminate things, okay? Use what you know to either guide you to the right things or to eliminate things. You're not going to know anything, but you should know enough that you can pick out a word or you can pick out an activity that could be like, well, it can't be this, but it could be this. And you really shouldn't be 100% guessing unless it's really, really, really a topic like they ask about, I don't know, endocrine, Marfan's disease disorder or something, and you're like, what the heck is that? Then you're really just guessing, right? But if it's something you know a little about, if it's about a PCL, if it's about scoliosis, and you know something, use what you know, okay? You really should know enough to be able to pick things out and think critically. Take your time with the questions to do this process, but don't take your time where you're overthinking and spending 5 minutes on something. By that point, guess and move on. Better to guess something and maybe hit it right by luck than to not get the point because you didn't even try, right? It's like playing the lotto. If you don't ever play, you're definitely not going to win. But if you do play, you might win. It might be one in a million chance, but there's a chance, right? Again, it is multiple choice, but there is pictures, there is videos, there is case studies. Although your choices will still be A, B, C, D, you want to, again, think about the topics and how they could be presented in these ways, either visually or have the patient doing something or whatever, and you got to figure things out. Of course, things that are more dynamic will probably need more video, like a gait stuff and whatever, but we'll get to that topic when we get to it. And yeah, I think we'll stop there for today. Thank you.